I'm an MS4 at Texas A&M College of Medicine, and this is a case that I saw with my mentor, Dr. Nicole Fram, at her practice at Advanced Vision Care. This case is titled the Monocular Corneal Decompensation Necessitating Endothelial Keratoplasty and Explantation in the Setting of Bilateral Iris Implants. I have no relevant financial disclosures to disclose. And as an introduction, there are currently non-FDA approved artificial iris implants that are used for cosmetic changes of iris color. One such example is the Bright Ocular Iris implant, which has been marketed as a safe for the human eye iris implant that you can obtain outside of the US, even though this is a US company. There have been multiple case reports of serious morbidity associated with the Bright Ocular implants that have then required explantation. This case in particular focuses on the management of a patient with bilateral Bright Ocular implants that resulted in significant morbidity in one eye that required the eventual explantation in said eye, but also the prophylactic removal of the implant in the other eye. So our patient was a 37-year-old healthy female that had both eyes implanted with the Bright Ocular Iris implant, who presented with chronic blurred vision in the right eye that had worsened over the last month prior to her presentation to us. Before she presented to us, the patient had a history of headaches and photophobia that was recalcitrant to medical therapy. She then sought out bilateral Bright Ocular implantation in India. That was then followed by LASIK OU that was stable for 4 years. However, she then developed uveitis in the right eye that was managed for 2 years with bromfenac and prednisolone. She then presented to our clinic after 6 years after the initial surgery with chronic corneal edema, steroid response, and vision in the right eye. On the images on the right, you can see a slit lamp photo of the right eye, which shows the artificial iris implant over the native iris, along with some corneal edema inferiorly and centrally. On the bottom image, you can see the left eye, which again has that artificial iris over the native iris, but without corneal edema. On examination, the patient had count fingers at 3 feet visual acuity in the right eye and was 20/20 -1 in the left eye. Their intraocular pressures were 18 in the right and 9 in the left. They had no RAPD in both eyes, and there was LASIK flaps OU with 1+ central edema, 3+ microcystic edema, and an inferior bullae in the right eye with 647 microns of central corneal thickness by pachymetry, with a clear cornea in the left eye with only 497 microns of central corneal thickness in the left eye. There was trace cell and trace flare in the right eye with scattered PAS, but the anterior chamber was quiet in the left eye. There were Bright Ocular artificial iris implants in both eyes and trace cortical changes in the right eye, but clear lenses in the left eye. Further diagnostic testing showed and verified increased corneal thickness in the right eye on pentacam when compared with the left eye. And you can see the pachymetry mapping here in both images. Preoperative endothelial cell counts also showed greatly decreased cell counts in the right eye, which were consistent with corneal decompensation. You can see here that the cell counts were unable to calculate how many cells were present in the right eye, whereas the left eye showed normal endothelial cell count with mild polymegathism. Hello, thank you for being here. So I had a question for the panel. What have your experiences been with these cosmetic iris implants, and how do they differ from FDA-approved iris implants that you've used?
Oh boy, where to start? Well, first of all is the indication. I don't think that any of us in the panel group and most of us in the country would consider placing a therapeutic iris prosthesis for the purpose of color change. Secondly is certainly the sequelae of placing these things into the anterior chamber. There is a really long litany of case reports, case series of blinding consequences from these devices. And I believe that there is one short-term case report where it was retained for a short period of time with good vision in the world literature. So I think that the therapeutic iris prostheses are a wonderful tool in our armamentarium, but not for color change. It amazes me what some folks will do and choose. And I kind of wonder whether there's some sort of difference in perspectives on the people who would choose to fly out of the country to do something like this with clearly very little background research, because you can do a quick Google search and find out all kinds of challenges. Nicole, you've seen, I think, more of these than I. Is there something personality-wise that you've noticed with the folks who choose this?
Well, it is an interesting comment. A lot of them are influencers and really want to change their eye color and get influenced by what they're seeing on Instagram. And when one person does it, it just catches fire and everyone wants to do it. This patient was really interesting because she was not an influencer. She actually had chronic photophobia and headache, and someone somewhere in the rabbit hole of the internet said, hey, why don't you get an artificial iris implant? And so I found that it was curious why she even thought, or anyone would advise someone that putting in an artificial iris implant would help with photophobia when she didn't have transillumination defects and she didn't have any other issue that would move her in that direction. So that was the first thing that was curious. And then what was also curious is that she was a normal person and she really thought she was making the right decision. So I do think there are personality traits, and I do think that just having it on the website saying the FDA it says on their website, the FDA has approved an artificial iris. Well, that's the human optics artificial iris. That is not the bright ocular. And they use that to then say, so this is safe. And that's what I find most concerning, is that it's deceiving to, whoever's coming on their website and inquiring.
Boy, I think it's concerning on so many different levels. Your comment about what did the implanting physician have in their mind thinking that this was going to reduce their light sensitivity. And I hate to be a bit of a cynic here, but my suspicion is that they were far more interested in when the money transfer cleared than whether it was going to theoretically reduce any light sensitivity. If we look at the history of implants that go into the anterior chamber, whether ACIOLs, iris clip lenses, or even glaucoma tubes, which we have to place for people with lousy glaucoma, they all eventually damage the endothelium. I haven't taken out an ACIOL for corneal decompensation since earlier today. So these things come up pretty commonly. The literature is quite clear on it now for decades. And it's a bit of a mystery why anybody would actually think otherwise, especially with the long history of data.
I think it's also important to clarify that this is an implant that's going on top of the iris. And what it does is it causes an iritis, it causes endothelial damage, and it can cause permanent damage to the underlying iris. So even though it's not necessarily rubbing directly on it at all times in all places, the uveitis releases pigment and clogs up the trabecular meshwork. It can cause PAS, peripheral anterior synechiae, and intractable glaucoma that needs to be managed by tubes, and the eye needs to be managed with an endothelial keratoplasty. They inevitably develop cataract. She's been treated for some time, for 2 years, with steroids. Drops that also will contribute to early cataract development. So it's just basically, a train wreck waiting to happen.
And I just have to ask, did it actually help her light sensitivity and her headaches?
She said that it did, until she became photophobic from, the microcystic edema and the headache, and she had ciliary flush at different times. So she did believe that it helped. I mean, I really, I always, it explains a lot. I do have a master's in counseling psychology. Everyone's like, that's why you're so special. But I was really thinking I was going to get it out of her and she would finally admit, okay, I just went there for eye color change. And it wasn't, she's just not that person. And you'll see what kind of courage she displays in the upcoming videos.
All right. So, Dr. Snyder, given the findings, what would your next steps be for this patients for treatment before we get into the next videos?
Well, I think that the literature is really clear on this. These things have to come out. They absolutely must come out. Depending on what else has to be done in the affected right eye, obviously the corneal decompensation will have to be addressed. And one could make an argument that perhaps it might recover somewhat with removal of the device and removing the insult of the inflammation, maybe throw on a little bit of Glanatec from Japan, maybe a couple of incantations, but the odds are it's going to be going to keratoplasty. And of course, if there's any underlying glaucoma issues and other iris issues underneath, which we really don't know about yet because the opacity of the device prevents us from understanding that, this is not likely to be this person's only procedure. And the opposite eye, well, it's got to come out there too. Maybe we can get away without quite as much intervention.
Right, so they're always counseled ahead of time that we'll take the iris out, but there may be transillumination defects. So even though it's rubbing anteriorly, it's the posterior iris that starts to slough off. And then they can have ectropia and uvea of the iris, the pupillary margin, and they can have correctopia and all kinds of issues that then may need to be managed actually by the human optics artificial iris, ironically. So these are all things that we counsel ahead of time: endothelial keratoplasty, need for cataract surgery down the future, and most importantly, need for a filtering procedure to manage the glaucoma from the peripheral anterior synechiae.
Okay, so let's go into the surgical video.
So this is our patient who had the bright ocular artificial iris implant. And what you notice is it's a pretty hazy view. We're putting in a miotic to bring the pupil down as we have to make some manipulations and we don't want to hit her natural lens. Viscoelastic is going underneath the bright ocular iris and over the natural iris, and that's to make space. These are the Snyder-Osher serrated scissors, and they're really nice because they hold as they cut. And so here we're just cutting and then checking to make sure we're not cutting the natural iris, and then using some 23 gauge forceps here to give us a handle and counter traction. There's different ways to take this out. Some people just grab it and take the whole thing out. I could have done that, but I think it's nicer to learn how to take it out without damaging endothelium. We were planning on doing a combined DMEK surgery here. In this case, I'd like to use the Snyder-Osher scissors to bring it also towards my incision, and then we can switch with the 23 gauge serrated forceps to bring it out through a 2.4 millimeter incision. So we're just rotating this around, and once you get the first two pieces out, then you can take out the other half on its own. But it's really important to always pay attention to where you are, and so constantly looking to make sure you're not hitting the underlying natural iris is really important, and blocking with a spatula as you're coming out is truly important here. So you're going to see a perfect example of that right here. So it actually feels like construction paper. It's a really interesting feeling. And then, you practice your puzzle making skills and put it together just so that you can make sure that you got all the pieces out. So next we want to prepare the eye for an endothelial keratoplasty. And so what we're doing here is first making sure that we can do a peripheral iridotomy because we don't want any pupillary block. We're going to do this first by scoring the endothelium to prepare for the DMEK, and then we'll do the peripheral iridotomy. So here we're scoring. When we do a DMEK procedure, we want to be just outside of the 8 millimeter zone so that we don't have overlap of our DMEK, and we're basically bringing Decimase towards the center, making sure not to make too many radial moves to have tags. And this is a pretty routine DMEK here. Now you can see the lens. It has pigment on it. It has an early cataract forming. But in this case, we wanted to perform a phakic DMEK and then come back after the cornea has regularized. Because remember, this patient had LASIK. So we want to get the most pristine cornea and the best calculations before we go to surgery. You can see also pigment adherent to the anterior capsule and how wild the iris is. And the iris is like that because it's lost a lot of its tone because a lot of pigment has been released. Sometimes using a vitrector and irrigating, it causes you to be in reverse pupillary block, and we can't get the PI with the vitrectors. So here we used a combination approach by using a reverse Sinskey and then also using the vitrector, and confirm that we have a nice open inferior PI. You can do this in the office, but she had too much corneal edema to see. So next we're inserting the DMEK tissue. And when you're inserting DMEK tissue in a phakic eye, you have to kind of realize that you're going uphill and then you flatten out. So it's not like a pseudophakic eye where you could just shoot it right in. And so you have to get past their lens and their natural iris before you can really know that you're free to pull the inserter out. Next, we just do our tap technique, and eventually we do a Derusimer technique to unfold the iris. At one point, some little bubbles came in, but they didn't get in our way. And now we're just centering the DMEK graft. And so everything, has gone according to plan for this patient, which we were very excited about. But the patient was counseled that she may have transillumination defects that would require an opaque contact lens. She will need cataract surgery in the future. And in addition, she may need a filtering procedure because you can see how much pigment was released during the procedure. And here we're just maintaining an air bubble for approximately 10 minutes. We do not use gas when it's a phakic IOL because we don't want to cause problems to the natural lens. And then when we do an air fluid exchange, the key is to have the meniscus of the air bubble in front of your inferior PI to prevent pupillary block and issues with more iris damage and uricebolia from high pressure postoperatively. So the case finished up very nicely, and we're happy so far with the outcome that we had for the patient.
I think it was an elegant way to remove the device in pieces so as to limit any endothelial contact. I really loved your technique, and I loved the way that you guided it gently along in a radial, or it's going to be in a clockwise fashion. It's really scary when you look at the spikes that are going out the edges of this device. It seems that it was extraordinarily well designed to cause inflammation. It takes all of the lessons that we've learned from history and combines all of the what not to do's and creates it in one device. So it's no surprise that it performs as it does. But it was a beautiful procedure for a frightening implant.
Well, it was great because this was the first time I ever took one out, and I knew I was doing an endothelial keratoplasty. So I said, instead of, thinking that I'm not doing it, let me pretend like I needed to preserve the endothelium and try a different technique than I'd just seen a lot of videos on just yanking it out in one piece. And I just felt like that wasn't necessarily an approach that was the most elegant for the endothelium. So taking 2 quadrants out and then the half seems to be a nice approach for these eyes.
I think it was a really wise approach, and I really like the way that you thought about treating it as if the endothelium was going to be there forever, because I think that we get into habits. And when we build good habits, they serve us well in the future. And when we build bad habits, we can potentially make errors in the future when we might not be thinking about it in the same way. So I think it's just a testament to your mentality as a gifted and meticulous surgeon to treat the endothelium kindly, even when you're going to be removing it in a few minutes.
Okay, so thank you for the perspective and experience. Let's go into the discussion and results. Following diagnostic testing and discussion with the patient, it was decided to proceed with explantation of the artificial iris and a DMEK, which was then performed in the right eye. The image on the right shows an image from postoperative day 3 with the bubble still in place, but the DMEK attached and the artificial iris successfully removed. Visual acuity did improve to 20/40 in the right eye, but there were residual diffuse TIDs, 360 degrees. And the patient also had iris that hung over the pupillary rim due to complications of the iris implant, in addition to developing a visually significant cataract. You can see on the slit lamp photos to the right, on the top you have the iris hanging over the pupillary rim, and on the bottom you have the transillumination defects that are highlighted there. 6 months after the artificial iris explantation in DMEK, cataract surgery was then performed, and since then the patient has now had an uncorrected visual acuity of 20/20 - 2 in the right eye. Now, despite the left eye not being symptomatic and having 20/20 visual acuity in the left eye, the abrupt presentation of the right eye and the risk of developing PAS called for the explantation of the artificial iris in the left eye. So after lengthy discussion with the patient after the right eye stabilized, it was decided that the left eye explantation would be performed. The surgery was then performed without complication, and the patient still retained visual acuity in the left eye of 20/20. You can see here the pre- and post-operative endothelial cell counts. The figure on the left was shown before, showing the very much decreased endothelial cell counts on the right eye with normal cell counts on the left eye. And post-operatively, after the artificial iris explantation and the DMEK in the right eye, those cell counts have become much more normal in the right eye and have remained relatively normal in the left eye. So why is this case important? This case illustrates the perils of introducing non-FDA approved foreign bodies into the eyes of a patient. And although the patient was largely stable for 4 years after her initial surgery, the patient then developed a recurrent uveitis monocularly that, after 2 years of medical management, was followed by an acute on-chronic corneal decompensation and anterior uveitis that required urgent explantation and endothelial keratoplasty, while also placing the patient at risk for developing secondary glaucoma. Luckily, after the iris was removed, the patient's visual acuity was able to be returned to 20/20. But despite that, and despite the continued stability of the patient's left eye, the risk of potential adverse effects warranted explantation to avoid corneal decompensation or other undesirable outcomes. This demonstrates a delayed onset of complications in the setting of non-FDA approved bilateral artificial iris implants, as well as an avenue of management in the case of monocular complications with binocular artificial iris implants. These are my references. Thank you for your time. So another question for the panelists. In your experience, how do these patients do long-term after implant removal?
Well, I think that most of these people will do pretty well once their other pathologies are managed. I think that some of these patients, at least in many of the case series, have significant optic nerve disease as a result of glaucoma prior to presentation for explantation. Those folks obviously aren't going to do quite as well. So that's a challenge in and of itself, which can be long-term vision limiting. And of course, we think about corneal transplants as being a one and done in our elderly population, with the average corneal transplant in this kind of a setting, perhaps in the absence of a tube, lasting maybe 10 to 15 years, and in the presence of a tube, maybe lasting a whole lot less. So many times this is going to be the start of the patient's journey, not the end of the patient's journey, and they will have a lifelong relationship with their ophthalmologist, even when things go super well. I liked that picture that you took afterwards that showed the iris pigment epithelial scroll hanging. It actually looked like the emoji for a crying emoji, and it was so apt because it really
I was just like, it wasn't
so
there.
sad.
And then when the pupil came down, I was like, what is that? And it was just hanging there. I was very excited at the cataract surgery to get it. But I have a patient right now that we had to remove emergently bilateral and do bilateral on-med tubes. And now we'll need endothelial keratoplasty and cataract surgery. And it's devastating. She's 23. And so I think that when they don't have a significant amount of PAS or the uveitic picture that presents and it's really just endothelial failure, they may do better. But when they have that uveitis and PAS and all of those issues in the angle, that's when it gets really devastating for me because now they have zero functioning angle. Just like Mike said, they have a tube. That means any endothelial keratoplasty that we do may only last 3 years, 4 years. Now, maybe with cultured endothelial cells in the future, we'll be able to kind of just inject cells and fix things in a different way. But for now, you're committed, if you have a tube to needing a transplant maybe every 4 years.